I'm just going to take you through some of my work, what we're doing and where we're going. If you've seen a previous talk of mine, you might recognize a few slides. I know you'll remember them exactly, right? Maybe not. So anyway, this how has been, scientists have been working on answering this question for quite some time. We have known for a long time that people who exercise regularly have lower incidence of cardiovascular disease, diabetes, and many other inactivity-related diseases. So we've been looking to determine, well, how does it work? And that's one of the questions I have. How does it work? Well, the American College of Sports Medicine has taken notice, and we've known for a long time, those who do research, but clinicians are more aware now of how important it is to exercise. And in fact, this is a vision of the ACSM to make physical activity and exercise a standard part of a disease prevention and treatment program. So not only is this of interest to researchers who want to figure out how it works, it's certainly of interest to clinicians because it supports making exercise a part of this prevention and treatment plan. Okay. Specifically, the work I'm going to show you is most related to resistance training, or that's what I'm interested in. How does resistance training influence these parameters? Most work has been done with aerobic training or endurance training. We certainly do know it's good for you and it reduces risk of cardiovascular disease. But in some populations, resistance training may be a better option. So we're going to look at that today. Okay. So what does the immune system have to do with heart disease? Well, it has everything to do. Okay? The common link between many inactivity-related diseases, including diabetes, cardiovascular, atherosclerosis, Alzheimer's, many other diseases that are associated with that inactivity, the common link is inflammation, inflammatory cytokines. In fact, cardiovascular disease is actually known as an inflammatory disease. You have a buildup of lipids in the arterial wall, or there's damage there due to hypertension, increased hydrostatic pressure there, and our white blood cells do their job. They go in and filtrate and try to correct the damage. However, if you don't remove the insult that's occurring, the hyperlipidemia or the high blood pressure or whatever, it's kind of a futile cycle. And I've got a picture to show you, just a little cartoon, shortly. So in any case, that's a link. Inflammation is associated with all of those diseases. Okay? The metabolic syndrome, most of you probably know what it is. We're at risk for the metabolic syndrome if we have several of these risk factors. Of course, I've mentioned hypertension, diabetes or insulin resistance, dyslipidemia, obesity, particularly central obesity, and it's been suggested that they add another risk factor, which is a pro-inflammatory or pro-thrombotic state. So I'm interested in how exercise affects this whole process. So let's look at adiposity. One of the studies that I'm working on now, that we just finished and that I'm working on now, examines inflammation in obese persons. Those with increased adiposity have an increased pro-inflammatory mood. What does that mean? You're going to find elevated levels of many different inflammatory-related proteins circulating in the blood. Fatness. Adipose tissue. Yeah. I told you. Yeah, adiposity is fatness. So the more you have, the greater amounts of these inflammatory proteins you have circulating in the blood, not only in the blood, but in muscle tissue, in fat tissue itself, many, many tissues, endothelial tissue.
And that's because they're acting on the fat, trying to get rid of it, or the fat stimulates this increased activity?
The more fat you have, okay, I'll be even more specific. Yes, fat cells, the more you have, they produce many of these inflammatory markers. And that production by the adipocytes, the fat cells, actually calls in some of our leukocytes, our white blood cells, monocytes, and they invaginate, and again, I have a picture shortly, they invaginate into the tissue and differentiate into macrophages. And the macrophages in adipose tissue are highly inflammatory, and that leads to these inflammatory cytokines, TNF-alpha and IL-6, can both directly inhibit IRS1, insulin receptor substrate 1, and the insulin receptor, and blocks or reduces insulin sensitivity. So there's something going on in the fat tissue, maybe different mechanisms, but something that stimulates these macrophages to try to correct, in this case, you know, I don't know if it's just the total fat load in the adipose tissue. In the artery, it's certainly damaged due to increased lipids and increased hypertension. So that's actual damage. So there are many different mechanisms that could be going on to stimulate the inflammatory response. So in any case, there are several different inflammatory markers here. I want to point out adiponectin. It has basically an opposite response. It is a hormone produced by adipocytes, but it blunts inflammation. So you could say that it helps to control overall inflammatory activity. In obese individuals, you have a reduced adiponectin along with the increased pro-inflammatory markers, which of course contributes to many different things, but notably endothelial dysfunction and insulin resistance, with both contribute to atherosclerosis. Let me show you a couple other slides here in a second. I'm not going to go through all of this, but real quickly, two of the markers that I usually examine and that are examined in the literature are pro-inflammatory cytokines, including interleukin-6. Okay, it's produced on all tissues, especially upon activation, like injury. Okay, it is a pro-inflammatory cytokine. Therefore, it stimulates inflammation. It has some anti-inflammatory properties as well, but high levels are associated with insulin resistance. It's elevated in obese persons. It's also highly associated with osteoporosis, increased bone resorption. Let's see, and it's of course significantly correlated with percent body fat, BMI, and even blood pressure. Tumor necrosis factor alpha, TNF-alpha, is a major, probably the major pro-inflammatory cytokine. It's the first one produced in an inflammatory reaction. Okay, its gene is overexpressed in obese individuals and diabetics, so we know it's related. It's been shown to actually, again, block or reduce receptor expression of insulin receptors. So it does technically, per se, reduce insulin sensitivity. It leads to, one of the results of high TNF-alpha is an increase in lipolysis. So you might think, oh, that's awesome. Lipolysis means the breakdown of fat in your adipose tissue, in your fat tissue. All right, I'm going to burn it. Well, what happens is, if you're inactive, you're not burning it. It simply leads to an increase in plasma triglycerides and very low density lipoprotein, so it increases your circulating cholesterol. Okay, this is associated with plaque formation and Alzheimer's disease and many other cognitive diseases. In fact, those who have clinical depression or other types of psychological disorders usually have a heightened state of inflammation, including many of these markers we're talking about. And of course, the TNF-alpha is also correlated with obesity and insulin sensitivity. You might hear me mention IL-1 beta, that's interleukin-1 beta. It is another pro-inflammatory cytokine, kind of TNF-alpha's buddy there. And then there are many anti-inflammatory cytokines. We know that the body regulates itself, so it has to have a balance, or at least in a healthy person. So you'll hear me mention interleukin-10. It is a major anti-inflammatory cytokine. It helps to regulate and blunt the actions of these more pro-inflammatory cytokines. So you'll hear me mention it. That's IL-10 or interleukin-10. Another molecule I want to mention real quickly, this one some of you may be familiar with. It's called C-reactive protein, or CRP. A blood CRP level now, above 3 milligrams per liter, does define an inflammatory state and a high risk of cardiovascular disease. Now, if you go to the doctor, everybody knows high cholesterol is bad. Many of you may have asked your doctor, let's measure my cholesterol, you know. But you might not know about CRP. It is now a clinical marker. It is used by physicians commonly now to assess risk of cardiovascular disease. Let's see, equal to or above than 3 is high risk. 1.1 to 2.9 is moderate risk. And then below 1 would be a low risk. So it's used by physicians now. Unlike some of the other markers we just talked about are more examined within the research area, but this is an actual clinical marker. Okay? What is CRP? Well, it's a acute inflammatory or acute phase reactant produced predominantly in hepatic tissue, or that is the liver. And it's produced in response to IL-6 and some of the other cytokines we just mentioned. So if there's an inflammatory response going in some of the tissues, the fat, the endothelium, wherever, the cytokines produced there travel through the blood, stimulate IL-6 release from the liver. We just mentioned this. It is a predictor now of future cardiovascular event. But the liver is not the only site. It's also produced in inflamed adipose tissue. And that doesn't mean by injury, like inflamed as in an obese individual. Okay. So it is produced by the adipocytes as well as those macrophages we talked about that invaginate into the cells. Okay. And of course, these data support the link between adiposity and circulating CRP being an inflammatory state. And in fact, some nurses in here may recognize, I think it was in 2010, so not that long ago, a statin drug for high cholesterol was actually approved to reduce high levels of CRP even in the absence of high cholesterol. The statins are hypercholesterolemic drugs, right? They reduce it. CRP, being recognized as this inflammatory molecule, can now be treated with the same drug even in the absence of hyperlipidemia. So, enough about CRP for right now. Here's one of those pictures I mentioned to you that illustrates a little cross-section of the blood vessel here. This would be the endothelial layers here. And we see just a normal monocyte, one of our leukocytes, traveling by. In a person with in an inflammatory state, they express more of these adhesion molecules, which makes it stick to the endothelium and therefore migrate into the tissue. They differentiate into the macrophages I just mentioned, and these macrophages do their thing. If they're stimulated with, well, endotoxin, heat shock proteins, you might not know what those are, but oxidized LDL, low-density lipoproteins, or bad cholesterol, will stimulate macrophages to release inflammatory cytokines, chemokines, and other molecules that we've talked about in order to call in more molecules, blood cells rather, but specifically white blood cells, of course, to help try to reverse this damage that's occurring. And in turn, the inflammatory cytokines also create more inflammation or tissue damage. Also due to other cells that are coming in, neutrophils can actually cause damage as part of the cleanup response. So what happens again is the plaque in the arteries or the fat tissue, monocytes in the fat tissue produce these cytokines, and they stimulate CRP release from the liver. And so CRP is a good marker. My interest in this area started with a resistance training study in elderly women. They were between 65 and 89 years old. They were 35. We had 3 exercise groups, and I meant to take that out, but some were taking hormone replacement, some were not taking hormone replacement, and some were taking Evista, which is a selective estrogen receptor modulator. So we just wanted to see if these different hormone conditions affected some of our results, and they did not. So we had a non-exercise control group along with the exercise groups. And they were all apparently healthy, some taking medications. The general BMI was relatively low for elderly folks, 26. 25 and above, or 25 to 30 is considered overweight. 30 and above